I think a couple things to note are both Chris and Nick are going and moving to Vancouver. Chris back to his hometown in Vancouver, British Columbia in Canada, Nick to Vancouver in Oregon across the river from Portland. So they have that in common. The other thing they both have in common is they both have young children and they're moving west, and their wives are flying out with their children, and they are both driving cross country with their dogs because they don't want to fly their dogs in airplanes. And so Chris is going first, Nick is going second, and we're hoping to have blogs from them about their experiences crossing the United States in a car with their dog. So they're both dog lovers, and I think they have a lot in common in that regard. But I've enjoyed very much working with them this year. And to start off with Chris, Chris did undergraduate at McGill University. He's originally from Montreal. Did a master's at University of Toronto, Master's of Science, and then has done his medical training at the University of British Columbia in Vancouver, both residency and fellowship. And he's our first fellow in the DCRI from the University of British Columbia. We've had numerous fellows from Canada, but we've really enjoyed getting to know Chris and others at his institution, where they're really engaging and developing a much stronger base for clinical research. And he will be going back to be a cardiologist in the faculty at the University of British Columbia, and will be supported by them to develop further their research in that area, and they have really great potential in the province. And so Chris today will talk about some of the research that he's done in this area. We'll do question and answers, and then we'll do Nick's during the second half.
Okay. Okay, well, thanks for the introduction, Matt. It's my pleasure today to talk about some of the research I've been doing over the last 2 years here at the DCRI. So I'll be speaking about out-of-hospital cardiac arrest with a focus on prognosis and strategies to improve survival. I have no disclosures. Let's start with a story. This is a 45-year-old male. He has a 30-pack year smoking history. He has no past medical history, and he doesn't take any medications, but I suspect he probably doesn't see the doctor very much. He's reasonably active. He works in construction, and he jogs 15 miles per week. He's brought into the ER by his friend, and he's complaining of excruciating substernal chest pain for 2 to 3 hours, radiating down both arms. And then while he's being examined by the resident on call, he collapses and is found to be pulseless, and CPR is started immediately, and an ECG is obtained. This is the initial rhythm strip, and what you can see here is this coarse ventricular fibrillation, which he has for about 20 minutes, and he receives one shock from the defibrillator, and then he comes back into a sinus rhythm with sort of an ugly-looking wide QRS. His subsequent ECG is shown here, and it's most notable for an acute anterior MI, and he still has persistent ST elevation, particularly in V4. So he obtains return of spontaneous circulation within 20 minutes. He's initially unable to respond to commands following ROSC, and he's intubated. He spends 2 days on the ventilator. He's extubated. He has some amnesia, but no other neurological deficits. He's treated for an MI, and he's discharged to a skilled nursing facility for further recovery. So you may have noticed that the ECG doesn't look exactly like the ECG that we typically find today. This patient is one of 20 patients in the initial case series in JAMA, published in 1960, on closed chest cardiac massage. And I'd like to make 3 points. The first point is that prior to this CPR, patients actually had to undergo thoracotomy to perform direct cardiac massage. The second thing is that of the 20 patients in this case series, 70% of these patients initially survived. But I think most importantly for this talk, I'd like to draw your attention to the bottom of the screen. And this is sort of the end of the synopsis of this article published in 1960. Anyone, anywhere, can now initiate cardiac resuscitative procedures. All that is needed are 2 hands. And I would stipulate that this is an important message in 1960, and it's a message that we're still trying to communicate today. So there are 3 main objectives. The first objective of this talk is to understand prognosis following out of hospital cardiac arrest. 2, to describe current strategies to improve survival. And then 3, to talk a little bit about future directions. Sudden cardiac death, which is the most adverse consequence of out-of-hospital cardiac arrest, is an epidemic. So we can think about a condition like myocardial infarction complicated by VT or VF. That's our patient that I just described. And yes, the incidence of sudden death is actually quite high in this population. And when we look at the general population, the incidence of sudden cardiac death is relatively low. However, if we look at the absolute numbers, 300,000 to 400,000 people succumb to sudden cardiac death every year in the United States. So this is a major problem. And the causes of sudden cardiac death are multiple. I like this slide because it shows that coronary disease can account, both acute and chronic, for up to 80% of sudden cardiac death. And it's often silent. So sudden cardiac arrest or sudden cardiac death is often the first manifestation of coronary disease. And of course, there's some other more identifiable, potentially, etiologies, including cardiomyopathies, including hypertrophic cardiomyopathy, as well as some channelopathies as well. But there's a big problem in this country, and there's a big problem across the U.S., across the rest of the world in terms of how we treat cardiac arrest. These two histograms show counties on the y-axis, and on the x-axis we have survival rate and then survival with good neurological outcome. And this is from the CARES registry, which is a national U.S. registry for cardiac arrest. And what you can see is there's wide variation in survival depending on county. So it appears that where you live determines your survival. And so that's a big problem because when we think about we're not delivering quality care because there's such variation. And part of that problem perhaps is related to CPR training for the general public. And this is a nice paper from Monique Anderson and others at this institution showing wide variation in CPR training across counties in the U.S. So in the dark blue, we have the upper tertile in terms of rates of CPR training in counties, and in the lighter color, we have the lower tertile. So there's seriously wide variability. And it's so critical that in terms of our cardiac arrest outcomes and how poorly we've actually done, that the Institute of Medicine had actually published a report last year, and they entitled it A Time to Act. And they've made several recommendations in terms of how we're supposed to move forward in terms of improving outcomes for cardiac arrest. But I'd like to highlight the fact that 2 of these 8 recommendations focus on accelerating research. So accelerating research on the pathophysiology, new therapies, and translational science, but also focusing on the evaluation and adaptation of cardiac arrest therapies. And again, why is it so critical? Because when we look at prognosis, the overall prognosis is very poor. If we take 100 patients who have an arrest at school, at home, while shopping, of the 100 patients who are actually attempted resuscitation upon, only 40 of these patients, and I think this is fairly generous, but 40 of these patients will actually make it alive to the hospital. And then of these 40 patients, only 10 patients will leave the hospital alive. So this is a 90% mortality for a fairly common problem. Let's focus a little bit on early prognosis. And this is some nice data from the US, from the CARES registry, and from Denmark. And what we can see over a 4-year span is that, survival to hospital admission increased. Although I'd argue that a survival of like 27% and 21% or 22% is actually very low. So there's concern that these patients are not even getting to the hospital alive. And then when we think about prognosis in the hospital, they do very poor as well. So this is a nice paper from Mike Contos from Virginia Commonwealth and others, including Matt Rowe from this institution. This is an action registry analysis. And what you can see here is that if you have cardiac arrest, irrespective of cardiogenic shock, and the two often come together, cardiac arrest portends a very poor prognosis, even among people who get into the hospital, who are surviving the hospital admission. And then the overall rate of mortality in hospital is like 40% for those with cardiac arrest and MI compared to those with cardiac arrest with MI without cardiac arrest of about 5.5%. So the early risks are very high. But remember, there's a group of patients who leave the hospital, and until a few years ago, not much was really known about their prognosis, and it was assumed that they're probably going to do pretty poorly, but we don't really know. So this is a question that we asked ourselves here, and it's particularly important, though, because we spend a lot of money taking care of these patients in the hospital. So, like, are our efforts worthwhile we spend $120,000 a patient admission to try and get these people out of the hospital. But if they leave the hospital and they have very poor outcomes, are our efforts worthwhile? And so we looked at this question and published this recently. We looked at the long-term risks among patients who are discharged alive from the hospital. And these are patients who have MI plus or minus cardiac arrest. So we can compare cardiac arrest patients with MI to those with MI without cardiac arrest. And this was in a vulnerable population. This was in an older population because it's a CMS and action-linked population. And as prior studies, we found that the early risks were very high. 44% of patients died in hospital who had a cardiac arrest compared to 6% who only had an MI. And of course, we excluded these patients. And then because we excluded everybody who died in hospital, and we wanted to sort of start once they were discharged. And we were left with about 54,000 patients with an MI without cardiac arrest, and just over 600 patients with cardiac arrest. And even among these survivors, these patients have very high-risk features in hospital. So they have more shock, heart failure, they rearrest more frequently compared to patients with just MI, and they have more bleeding and require more transfusions. But much to our surprise, patients who leave the hospital alive with cardiac arrest do just as well, and even maybe a little bit better when we look at one-year mortality and readmission rates. So we actually found this very surprising, but this was actually quite positive. That they're not coming back to hospital and that they're not, that mortality is reasonably good. And here's some other data from Denmark, and this is from Christian Kragholm, who's one of our fellows who left last year. But he looked at the same type of analysis among those who leave the hospital. And he found that 3/4 of patients who leave the hospital with cardiac arrest eventually go back to work. And they become productive members of society, and at a median of 4 months. So if we take both of these studies together, if we get them out of the hospital, they're not coming back more frequently. Their mortality is reasonable, and at least in this cohort, several of them go back to work. And so taking this all together, we feel that the prognosis post-discharge is actually good, and that the early risk of adverse events in patients with cardiac arrest is actually attenuated after discharge. And so this supports efforts to improve our initial survival rates of cardiac arrest patients. So what are some strategies to improve into the pre-hospital and the intra-hospital setting? In the pre-hospital setting, bystander CPR, early defibrillation are key, as well as potentially systems of care. And in the in-hospital setting, we think about cooling the patient to reduce brain injury and then potentially coronary angiography as well. So this is a really nice study looking at pre-hospital intervention, and it was done in North Carolina. This was a study that was led by Carolina Hansen, one of our fellows here, Chris Granger, 4-year period, is they go public in CPR and automatic external defibrillator use. And you may have seen them at the county fair. They trained first responders. These are firefighters and police force in CPR as well as, because these are off, at the other end of the 911 call, and train them to recognize cardiac arrest so that they can be treated more appropriately and distinguish it from other things such as seizure. And what they found was over a 3 to 4 year period, there is in fact an increase in survival to hospital discharge in North Carolina by about 25% or more. And by 2013, rates of bystander CPR, I'm not showing you the trend, but they had increased to 49% and first responder defibrillation to 52%, which was great. Although I will argue that still half the patients in North Carolina are not receiving CPR. And this is after somebody has called 911. So what are they doing? They're just watching the person, or they're waiting for the ambulance to come. So we can still improve. But this is the most important figure, I think, from that paper, is that, and what it shows is that, what it describes is that who initiated the CPR and then who defibrillated the patient. And this is adjusted for age and sex. But what you can see is that if the bystander who calls 911 presumably initiates CPR, and if it's the bystander or the first responder that defibrillates the patient, then your odds of survival to hospital discharge are significantly higher compared to if you wait for the EMS and the ambulance to arrive. So I think the message is that you as a bystander have the power to actually improve survival simply by using your two hands. And we looked at this further depending on location of cardiac arrest, whether it's home or in public, because historically patients do much worse at home. And there may be several reasons for this, but typically it's a family member who finds the patient who has had the arrest. Potentially they're not trained. And you can see here that the initial rates were about half of survival, about half of those in public. But we were happy to see that rates of survival at home, even though not great, have improved with these interventions. So these interventions that have been performed in North Carolina have really made an impact in terms of survival. So now that we've brought the patient into the hospital, what can we do once the patient arrives at the hospital? And that's something that I'm interested in as a cardiologist and a CCU attending. So we first need to step back and say, well, what are these patients dying of? And this is nice data from the TTM trial. This is a hypothermia trial, a targeted temperature trial, and they looked at this. So 25% of patients are dying of cardiac causes eventually, and this is typically heart pump failure or reinfarction or rearrest. But 60% of these patients are dying of anoxic brain injury. And this is from what we call reperfusion injury. So when there's blood that returns to the brain after a period of cessation, there's free radicals and swelling in the brain, and these patients don't recover, and there's ongoing apoptosis and death. So these are the primary causes. And of course, there's other causes like multi-organ failure. So to sort of intervene, here are two trials that looked at therapeutic hypothermia to prevent brain death. And these are two trials that were published in 2002. And these trials showed that mild hypothermia, 32 to 34 degrees Celsius, improved outcomes compared to normal thermia, which is essentially letting the patient sort of auto-regulate their temperature. And so these have been in the guidelines for some time. But then in 2013, another trial came out, the TTM trial, as I mentioned. And this was a very nicely done trial out of Sweden. And they had over 900 patients compared to like 350 patients in their older trials. And they found that actually 33 degrees was actually equivalent to 36 degrees in terms of outcomes. And so there was a wrong message actually that came out of this when people started saying, well, we shouldn't cool people because what's the point? But the reality is that we should be targeting their temperature because we think that fever may be a problem in these patients. It can lead to ongoing injury. And so the guidelines have now, and these are the ILCOR guidelines, which are the international guidelines, but they're also reflected by the AHA, is that we should be targeting a temperature between 32 and 36. Although the evidence is somewhat lacking, we don't know what the best temperature is at this time. But these are what the guidelines say. And the guidelines also talk a little bit more about how do we prognosticate from a neurological standpoint, continuous EEG, a bit beyond the scope of the talk today. But I think from a clinical standpoint, we need to be waiting at least 72 hours, if not 5 days, following sedation to look to prognosticate these patients who are in our CCUs. Okay, so I talked about how we intervene from a neurological standpoint. What about the heart? Well, what do we do with a patient who comes in and they have ST elevation? Well, it's pretty clear. We need to do what we do normally. ST elevation indicates there's 100% blockage of one of their coronary arteries, and we should bring this patient to the cath lab. And despite some hesitation, there's really no evidence to suggest you can't cool the patient and bring them into the cath lab. That's very clear, and this is what the guidelines would support. But it's a little bit more tricky when we think about a patient who comes in without ST elevation. So this is someone who's had myocardial injury, but not necessarily 100% occlusion. And so the question is, do we bring them immediately to the cath lab? Do we call our interventional colleagues, or do we wait and cool them first? And there's been arguments on both sides. Well, I think the most important thing to think about is what are we going to find in the cath lab that we could potentially intervene upon? And I think the best data comes from this review, which summarized several observational studies. And they found that among these studies, if you bring these people to the cath lab, a quarter of them will have what we call a culprit lesion, which can be revascularized with a stent potentially, and 2/3 will have significant coronary artery disease. So I think that if you bring these patients routinely to the cath lab, the yield is actually reasonably good. So if we bring them to the cath lab, what's the data supporting any evidence that it changes outcomes? Well, we don't have a randomized trial, and there are several observational studies that are out there. Part of the problem is that there's a huge amount of indication bias. So if you bring somebody to the cath lab, you think they're going to be a survivor. And if you just look at that on its own, then they're going to do better simply because they have fewer comorbidities and simply because they're less sick. So I think the nicest observational study actually then comes from Paris. And the reason I like this study is because this was published recently, is because in Paris, they take everybody for a coronary angiogram, irrespective. There's no decision making, okay? It's not like the clinician decides who goes and who doesn't. So everybody goes. And so they looked at 700 patients with cardiac arrest who went for immediate angiography, and they had non-ST elevation. And the interesting part is that they found 30% of these patients had a lesion which we could revascularize, we could perform PCI, and these patients did better. So I think this is probably the strongest observational data suggesting that maybe we should be bringing patients to the cath lab routinely. And finally, in terms of intervention, maybe what we should be doing is bringing patients to hospitals which can provide all of this bundle of care in its entirety. So bringing patients where they can get ICU care, they can get cooling, they can get coronary angiography and neuroprognostication. And so can we learn from our STEMI system? So the group here, you know, as many of you know, have implemented STEMI systems in the region, then the state. And I was fortunate to be involved in this study where they implemented STEMI systems nationally in 16 regions nationally, including large cities you may have heard of like Houston, New York. And what they found is among the highest performing regions, you can actually, over a relatively short period of time, like a 2-year period, you can improve reperfusion times among patients who are presenting at those hospitals. And then we also showed that by merging survey data with action data, we could identify hospitals that actually implemented some of these processes of care. And we found that those hospitals that implemented care, and this is a cumulative distribution curve folded at the 50th percentile, that they had actually the shortest reperfusion times compared, for example, to hospitals that never implemented systems of care. And this was for a single call transfer protocol. So the idea is that can we learn from our STEMI systems and potentially operationalize cardiac systems of care, cardiac arrest systems of care. And there's not a lot of data out there, but I'll show you this one last slide here, again from Christian Kragholm, who presented this at AHA. And what they looked at, the question they looked at was, if a patient has a cardiac arrest, should we bring them to a hospital without PCI capability, or should we drive them to a hospital with PCI capability? And irrespective of the drive times here, we see that survival is highest among patients who are brought to PCI centers compared to those who are brought to non-PCI centers. And this persisted even after adjustment for several important potential confounders. So what's happening in the field of cardiac arrest now? There are a couple small trials. So there's another trial looking at cooling. This one out of Ottawa, which is looking to cool patients even further down to 31. So they're comparing moderate hypothermia versus mild hypothermia. And then one of the first trials looking at routine early angiography in patients without ST elevation, that's occurring in Arizona. And their endpoints are mostly safety, but that'll show some feasibility, hopefully. So if we come back to our patient who's 45, he's had a cardiac arrest. What went right? Well, he did receive early CPR and he did receive relatively early defibrillation, I guess, for 1960. It took about 20 minutes. He probably should have received some type of TTM, given his initial neurological deficits. And today he would have received immediate angiography for his STEMI, and potentially this would have been identified with a pre-hospital ECG in the field if he would have called 911. But we've still got several knowledge gaps and implementation gaps. And again, I mentioned we need to continue to educate and increase our rates of early CPR and defibrillation. We've known this, as I mentioned, since 1960 that this works, and so we need to continue to send that message out. We don't know what the optimal targeted temperature is, and there's more studies coming through. Perhaps we should consider systems of care. And then I haven't talked about perhaps any other in-hospital interventions that might help reduce ischemia reperfusion injury in the brain, for instance. But we have none of that so far, and those are under investigation. So I'll end to say that there's lots of work to still be done. Here at Duke, we have a linked data set, which is de novo. It's the first data set in the U.S. that has linked care as a cardiac arrest registry with action, so we can have granularity in terms of the patient journey in the pre- and in-hospital setting. We will be looking at TTM rates nationally through another in-action proposal, and we have provisional approval for another proposal from Improve It, looking at sudden cardiac death in a very stable population, so these people still die post-MI of sudden cardiac death. In British Columbia, we've got a large cardiac arrest registry, which was part of the Resuscitation Outcomes Consortium. It was one of the sites. That was an NIH group that performed clinical trials, and so we've got about 15,000 patients out there. And the nice part in Canada is we have a unique identifier, so we can link with a unique patient identifier, looking at long-term outcomes, hospital admissions, and even drug prescribing and filling information registries. And of course, we have a STEMI registry. We can look at cardiac arrest outcomes. So I'd just like to finish by saying I'd like to thank the groups that I've worked with for cardiac arrest in the race cars and accelerator groups as well as action. But I'd be remiss not to thank everyone else that I've worked with and all the other projects I've worked with here at Duke. And I thank you for your support, and it's been a great 2 years. Thank you. Happy to take any questions. Yeah, hey, John.
I'm sure. Oh, it's Mike. Are there any data or any moves or push about this deploying ECMO in the field for people that have had cardiac arrest? I mean, aren't there places in Europe that are doing this kind of stuff?
Yeah, there's like a famous picture from Paris. So they're really aggressive in Paris, where they're deploying ECMO in the Louvre. And so you can Google that. I think there's a lot of enthusiasm for that, but I think we don't know if that's helpful in terms of outcomes. It can happen in Europe because you have, often you have physicians who actually ride in the ambulances out there. So there's, from a feasibility standpoint, they're able to do it because they have, folks who are highly trained in putting in the catheters and things like that. So that's a good question. I think the jury's still out and people are interested though.
So Chris, I'd like to thank you for your great job here and all your contributions and ask you, I mean, one of the things you brought up that's a challenge is, so a person arrives alive to the hospital after a shockable rhythm cardiac arrest, and half survive and half die. And we don't know how long to continue trying to keep people alive when they're not making any sign of recovery. We just don't, we have very little information. Is that something that we could be addressing with some of these databases? A better ability to prognosticate, like at day 3 or 5, about who might still survive and is worth keeping on life support?
Yeah, I think there's a dearth of information. I mean, we have all these different modalities. We have clinical exam, and I think corneal reflex is the best examination technique at 72 hours to look for prognostication. But, we've also got EEG and other imaging, but none of this has really been looked at systematically in terms of prognosis. And I spent some time in the neuro ICU, and it's a bit piecemeal. I mean, they come down to the CCU and they consult on patients and they look at sort of the entire picture. I think it's ripe for further study if we can get a nice database with that type of granular data to really look at some of these variables. We do know, and as I mentioned, we should probably be waiting, at least 72 hours after sedation, if not 5 days operationally, to really make a call on whether we should withdraw care in these patients. But that's a huge knowledge gap. Thanks.
Thank you, Chris.
So Nick Wysham, who's our other co-chief fellow, went to medical school at University of Washington, Seattle. He did his residency at Oregon Health Sciences University in Portland and has been a pulmonary critical care fellow here at Duke Medical Center for the last 3 years. Likewise, he's also been chief fellow of the Learning Health System training program at the medical center, and his presentation will go through this, and has been a co-chief fellow here at the DCRI. And Nick will be assuming a position in large health system in Vancouver, which is across the river from Portland, and still working on a number of projects with many here. And he's really learned how to leverage big data for the purposes of clinical research and improving clinical care. So we're looking forward to his presentation, and also wanted to thank him for all of his efforts in being a co-chief fellow this year at the DCRI.
How do we play this? All right. Okay, so this is the title of my presentation, Learning Health Using Patient-Supplied Data in Chronic Lung Disease. I'm going to start with some disclosures. I have a couple of research grants. recently developing a consulting arrangement with Rion Systems, and I will talk about their product briefly. But most of all, I'd like to acknowledge all the mentors and collaborators that I've worked with here. So here's an outline. I'd like to just briefly talk about what a learning health system is. I think many of the folks here will know. Talk about how I see this concept being useful in chronic lung disease. And then transition a little bit to some opportunities I've just thought about in mobile health technologies, and give a couple examples of how this might be used. Talk about some challenges and barriers, and then some ways forward. So this is kind of a picture of what a schematic of what a learning health system is. And in bold strokes, it's trying to use clinical data in real time to appropriately care for patients. And when we do that, we think of a lot of the registry type data that we're using, but can we make that live? Can we act on that data in real time? And can we use that data in multiple ways so it can be support clinical decision making as well as outcomes and quality improvement? The DCRI has multiple such data sources, and one of which that I was able to work with is called QDACT, and this is Arif Kamal, who's in the audience, runs this. It's a large national consortium of palliative care providers that document their care in this database. So one of the first projects I did with Arif was just to look at, I was interested in symptoms and quality of life in chronic lung disease. And so we looked at patients who had a palliative care consult with chronic lung disease and compared those to those who had a palliative care consult with lung cancer. And we showed that the symptoms of chronic lung disease at time of palliative care consult were very similar to lung cancer, with notable exceptions being insomnia and nausea being more prevalent in the cancer group. But we also had some other interesting findings. Patients with chronic lung disease were older, but they were more likely to be DNR. 62% were at initial palliative care consultation. They're more likely to recently have been hospitalized, less likely to have been seen as an outpatient by the palliative care doctor, a pretty big difference there, and more likely to have been seen in the intensive care unit. They tended to be sicker, so they're less likely to have a high palliative performance scale. But conversely, the majority of patients with chronic lung disease had a life expectancy greater than 6 months. So those of you who take care of patients who are chronically ill towards the end of their life, you can see that there's perhaps a gap here where patients aren't seeing palliative care sooner, or as soon as they ought to, and they're not yet hospice eligible either. So who cares for these folks? Done a couple other similar papers with other data sets and found that if you break apart chronic lung disease into interstitial lung disease and COPD, their end-of-life care is inferior to cancer care in multiple domains. And actually, there was just a publication that came out in JAN Internal Medicine from the VA that spoke to the same thing, that chronic conditions receive poorer end-of-life care than cancer. So why is that? Why is there this disparity? Well, we firstly have to acknowledge disease factors. Lung diseases are very difficult to prognosticate. They're relapsing, remitting, not linear in any kind of way. And cancer is a little bit more linear, and perhaps that provides opportunity for advanced care planning to better attend to end-of-life issues. But I think there are some specialty factors. In all areas of medicine, it's been tested in cancer and other areas, we underestimate the symptoms that our patients have. And I think cancers in oncology, they've done quite a lot to try to remedy this. And I'll say in my own specialty, I think we don't tend to manage symptoms proactively. We're very much attend to the physiology and this sort of thing, but don't really appreciate the whole scope of symptoms that exist. There's also been a description of therapeutic nihilism around dyspnea, and it's got kind of an eye-catching phrase, but really we don't ask about it or think that there's much that we can do about shortness of breath. So there's probably a lot of patients that could benefit for treatments for shortness of breath that perhaps that palliate their symptoms, but they're not getting them for a number of reasons. So what I think oncology is starting to do and is doing better and better is incorporating palliative care into their routine care. So rather than equating palliative care with end-of-life care, as we often do, they're finding ways to bring this into their practice, moving up the timeline. And one of the greatest kind of the big eye-catching trials with this, again, was in lung cancer, and they randomized patients to early palliative care in patients who had stage 4 lung cancer. And in addition to improving quality of life, as you might expect, they actually were able to show a survival benefit to palliative care. which was pretty interesting. But again, that's using a palliative care team. There's lots of reasons why that's not scalable, and probably is actually a little too late. This trial was also in cancer, and I didn't have anything to do with it, but they used an electronic patient-reported outcome system and incorporated them into oncology visits. And they were, again, so just screening for symptoms, didn't prompt any intervention explicitly. The only intervention was randomized between proactively assessing symptoms using patient-reported outcomes. And they showed, again, an improvement in quality of life. But they also showed an improvement in utilization and survival. And again, all it is just collecting the data. So you can see, a logic behind creating symptoms like this in patients with, severe and life-limiting illnesses. But as we think about a learning health system, again, we want one of the questions that comes up is this data that we're collecting at the point of care in clinic about symptoms, is it any good for research? Many of you who work in clinical trials know that the rates of missingness in survey instruments is actually quite high in clinical trials, and so there's all kinds of biases that come from that. But at Duke, we actually had something similar in the oncology clinics called the PCM. It was actually a very extensive, very long symptom reporting instrument. And we looked at factors that described why something might be missing. And we have lots of data points. So age was a factor, kind of as you might expect. Older ages tended to be somewhat more missing, but private insurance was stronger. One of the more interesting things that we found, though, was that the number of visits was pretty strongly associated with less missingness, kind of actually opposite to a lot of the clinical trial experiences. And this is depicted here. So with longitudinal care, missingness improves. And so I think this speaks to the fact that when patients find it takes effort to make a survey. When patients see that that's benefiting them directly, they're much more likely to act on it. But there were certain domains that were particularly more missing in this analysis, and one of them is the functional domain, and I think that's a real concern. And we can talk afterwards about reasons in this particular instrument why that might be more missing. So I started to think, does this apply to other conditions that are actually within my specialty? And there's a couple good reasons for this. I think one of which is the way that we're grading COPD now actually relies on a patient-reported outcome instrument. You can either use the MMRC scale, which is just a activity-related breathlessness scale, or this CAT score, the COPD assessment test, I believe. Much like in heart failure, the severity of your disease relies on the amount of symptoms that you're having. So we probably ought to be enacting systems to capture this kind of data within our care. And if you do so, then you can think about ways that might more appropriately step up therapy or any number of things, or bring other services to bear. And again, as I mentioned earlier, cancer and COPD are a little bit different. And what I wanted to illustrate here is that, if we think about assessing symptoms longitudinally over the course of a cancer treatment, they're seen every month or some regular interval. Patients with chronic lung disease are going to be seen intermittently. And in fact, the ones that are seen more frequently are probably doing worse. So there's going to be a selection bias in this. So really what we need to do is find ways to capture data between clinic visits. And I think that's going to be more actionable. So this is why I think there's promise in mobile health. As many of you know, there's all kinds of data that your smartphone and other device can collect. On board you have gyroscopes, and you can even measure heart rates and other things like galvanic skin response that I don't think anyone knows what to do with. There's all kinds of active tasks that you can do. You can blow or say ah or any number of things, or do spatial visual memory tasks. Survey instruments can be deployed by these. And there's a whole set of peripherals that, and there's more coming out on the market every day, but you can see how anything that we do in the clinic can maybe be brought to the patient in their home. But I think the real promise, at least in the short term, relies on things that are passive. So physical activity, many people are using Fitbits, but even just every phone that everybody has in this room is just counting your steps, whether you know it or not. And we know that physical activity actually correlates to all kinds of important things in COPD, quality of life. It correlates to likelihood of admission, and in this paper, likelihood of readmission within 30 days. So and what this paper showed is if your physical activity was increasing over time, that you're probably in the clear. However, it was falling, that you're more likely to readmit. So based on this, me and Jake Kelly put together a pilot project funded by DHI to assess the feasibility of post-discharge monitoring using activity and electronically patient-reported outcomes. And so the aim was just to see if this would work, and then secondly, if we could collect this data, could this data be actionable to predict or prevent readmissions? And we did this in both COPD patients and heart failure patients. And so this is kind of a schematic of how it was supposed to work. You can see this one patient, her activity was down here in purple and increased pretty dramatically in the early post-discharge period. This goes out to 2 weeks. And then in black is the summary score of her symptoms that she completed by email survey each day, and she didn't readmit. You see I'm only showing one patient's worth of data because there was actually only one patient that successfully went through this protocol, and that's a slightly different topic. But what we did learn is that there's a huge digital divide. There's a lot of barriers to this sort of thing, to actually deploying mobile health. And one of the major ones was that patients don't really have iPhones. Patients tend to come from lower socioeconomic statuses, and though more than 80% had a smartphone, almost all were Android devices, and our protocol only worked in the iPhone platform. We tried a couple of workarounds that relied on home wireless internet, but even that was a major barrier as well. But one of the other questions that came up is, so say you can scale this up and solve all the technology issues, what do you do? You're passively monitoring folks and their steps go out of range and fire an alert, then what? Well, at ATS, I walked past a poster, and these folks had a pretty interesting approach to it. They derived an app that tracks symptoms, but also has kind of a help me button. And in that, it takes through a symptom assessment that's more detailed, and basically provides the patient with some triage decisions. Now, this is based on several physicians basically looking through some created patient profiles, hundreds upon hundreds of these, and suggesting what sort of triage they are. So that makes a learning database that the algorithm then can apply and come up with a recommendation. So again, the patient goes through, fills out some information, and then it gives you a recommendation. And they're in the midst of trying to figure out how to then validate the device or the software. What kind of feedback do you get then from the physician, et cetera. Another way, I think, at that, kind of using the mobile health platform in this way is something I worked on with a REEF and was funded by the DCRI, and we're calling it PREPT. It's a question prompt list, and this is not the first question prompt list ever, but a question prompt list is a list of questions you're supposed to ask your doctor. It's been published in Cancer and in palliative care before. Never has one been made for lung disease or COPD, and this is one that I've been developing for COPD. And in a similar way, we've asked physicians to volunteer, what questions do you wish that your patients asked for COPD? And we asked them to tag some patient characteristics that would be appropriate for those sorts of patients. Would your more severe patients be more likely to ask about oxygen, et cetera? And so and these are a couple screenshots of the patient interface, but the patients can then go through the questions, pick ones that they want, put them in a data bank. That user data is tracked. They can also volunteer their own questions. And so then based on user profiles, it can suggest maybe the top 10 questions that you might find useful in your upcoming visit. And this is, the aim here is to kind of get at this, another issue that I didn't highlight earlier, that patients that I see aren't quite as engaged in their care as a lot of other patients, particularly cancer patients. And maybe, giving patients the kind of right words to ask their physician can help break that down. So Arif is currently running a pilot in the cancer space. This app, it's almost finished development, and we have plans to test it in lung disease a little bit later. There are also some research-focused apps. We've talked about the Research Kit platform here. This is one put out by the COPD Patient-Powered Research Network. It's a PCORI-funded patient-powered research network, and Duke is the data coordinating center for that. They have kind of a symptom tracker app, but what I find interesting is they're just now about to start a PCORNet trial, the second PCORNet trial, randomizing patients to roflumilast or azithromycin to prevent COPD exacerbations. And they're hoping to use this app as a way to enroll patients. So again, trying to reach patients as well as adjudicate outcomes using the app. That's not the primary way they're doing it, but I was talking to those folks at ATS, and they're interested to see if that's a usable research tool. So, but as I mentioned, there's some serious challenges to this approach. Access to health information technology is a big one. Our patients, particularly in our older patients, aren't all digital natives. There's a lot to teach them on how to use these devices. But I think there's other patient populations within my specialty and others that might be more ready use cases than COPD. There's compatibility between platforms and data sharing, and I mean by that I mean between a mobile health platform and a health network. So you can really, adjudicate, who is this patient that's using this? If a patient tells you have COPD, actually about 60% of the time they actually do. So there's a lot to learn about how to marry these data sources, and with that comes privacy concerns. And then there's also this issue about policy and the FDA. So if we're using these kind of novel tools as to help support decisions, do they need to be regulated as devices? And there's probably a lot of developments to come in that issue. And then lastly, I think we can use oncology and some other spaces that are a little bit ahead of pulmonary as a guide, but we do need to prove that putting all this effort into getting this data will actually benefit patients. So in summary, symptoms matter in chronic lung disease, and I think COPD in particular is a very prevalent chronic lung disease well suited for mobile health. And I think it's exciting because mobile health can allow new ways to understand disease. It gives you that opportunity to get the data between clinic visits. It captures novel data that we're not currently using, such as activity and other symptom scales. And it could probably enhance communication. And then maybe all that data could prompt interventions. And I think the idea of learning health, including mobile health technologies, can improve clinical care and research. But what I've learned from these projects that I presented is you really kind of need multiple angles. So you need, a reason for a health system to invest in this, and you need to build that with kind of a bigger vision in mind. So using QDAC as an example, they had a business case to build this, but then all along we're thinking, well, wouldn't this be a fantastic observational data set? I think that same model can be brought to a lot of different projects in this way. So lastly, I'd like to conclude by saying thanks to everybody, including the DCRI. I can say unequivocally, being a fellow at the DCRI has been a highlight of my time here in Durham, and I really appreciate the opportunity. Yes, sir.
So, who do you think is going to really provide the impetus to move mobile health into, regular healthcare and regular research? Because it seems like the IT companies, they're already selling their product commercially to consumers and so forth, and they're doing well. They don't really seem to have a strong business case. The EHR providers, for them, that's not something they really want to invest in because they're already providing EHRs to clinics and hospitals. The pharma companies, their products really aren't dependent upon mobile health, but clinical care could be improved. Clinical research could be improved, but we don't have the stakeholders there with the deep pockets to really move that forward and move mobile devices into more routine practice or into that level that would be qualified by the FDA as, certified research and meet all the standards that could be used for approval-based, therapies or even post-marketing surveillance.
Yeah. I think that those are great points, and I think there's going to have to be kind of an all-of-the-above approach. I've spoken to some pharmaceutical companies many pharmaceutical companies in the respiratory space are investigating smart inhalers, and these things have a capability of dose counting, which is kind of obvious. But then also geolocation. One that I found really interesting. Technique is a big issue with inhalers. So this one actually can count your inspiratory flow rate and tell you if it's too much or too little to get the adequate drug delivery, and then also feed that data back. So I'm kind of thinking of these like early warning signals so we can avoid acute care hospitalizations, and they're actively investigating inspiratory flow, which is something we don't generally check. We check peak expiratory flow, but inspiratory flow is an early signal. So frequency of rescue inhaler use, all these sorts of things. And then in terms of who pays for it, the payment landscape continues to evolve. The same company was talking about how they're negotiating risk contracts with payers. So they, for example, will provide a whole suite of medications to care for asthma. And we know that people are about 50% adherent to their controller medications, and that's the strongest predictor of admission and other such utilization. Well, now if the pharmaceutical company is on the hook to ensure that a patient is using their inhaler appropriately before we give them a biologic, perhaps those are the patients that they're going to target with these sorts of interventions, adherence interventions and others. So I think that the landscape will continue to change this way. There's tons of integration in the healthcare space, both from providers and insurers. It's a matter of time. But you're right, and then space moves so quickly. How do you actually put together an intervention, show benefit before the technology's moved on? So I think it's pretty exciting, though. A lot of opportunity.
So really interesting to hear about some of the passive monitoring approaches and the use of those data. They're obviously really rich data. I'm curious about the monitoring approaches that require some action from the patient, answering even a brief questionnaire about frequency of cough or wheezing. What's your perspective on incentives that are effective in helping patients to provide complete and accurate information consistently and over the long term, particularly for patient communities that may be less engaged and may not be as sold on the use of those data for research?
Yeah, I think that proximity to a major event would be you get deeper data or more frequent data. So this patient that enrolled was a really great subject and very engaged in the idea. And so every day she answered her email survey, which I didn't expect. But I'm sure as time, if I were to keep pinging her day after day, she would stop at some point. But she was also, this is her first ever COPD exacerbation and admission, and so she was really kind of rattled about it. And so then going forward, what's going to incentivize that? So, again, we've thought about some of these things. I think you can, cost is a huge issue. So if you again, you can't be coercive, but if you say if you use this app, then you continue to be part of the study of some kind. There's lots of ethics involved in it. I think the missingness is hard, but again, they have to get something back. So you can other incentives, but I think things like the triage. What do I do with the symptom? The community. Performance, how's my symptoms over time? These things will prompt engagement, and I think it's got to be multifaceted. So if we're just asking someone to enter data into an app, and the app's not giving anything back, they're not going to engage with it. But thinking about, taking a page out of Strava or those other kind of apps that show your performance over time, I think that's going to be one way. But it's a different patient too. They're not competitive cyclists, so maybe there's other engagement issues.
Like you had you enrolled the one patient, but there were also many challenges in getting other people in this study. Would you mind just briefly touching base on that? Like, what were the biggest challenges in getting people involved? Was it that they didn't want to? Was it a device issue, wireless issue?
Everyone we would have had probably 80+% consent rate if everybody could have enrolled. First, it was just the Android software platform being the only one they used, and then we actually got loaner iPhones, but the plan there relied on home wireless internet. And I think 3/4 of the patients we approached under that didn't have home wireless internet. They're smartphone dependent. So the folks that get admitted for COPD exacerbations in particular tend to be of somewhat lower socioeconomic status, a little less connected and engaged. A lot of these can be managed as an outpatient. So those were those barriers. And there's a couple of kind of software glitches, which are kind of mundane but important, that we ended up closing down the study because an app update pushed out and it broke the system for a couple of weeks and had to fix it. Yeah.
Were elderly patients, were they just as likely to have considered enrolling, or were...
The people who declined were pretty elderly.
Right.
Like late 70s.
Okay.
But this patient, and we consented 4 actually. We only got complete data on 1. She was in her mid to late 60s. But all right. Well, thank you for your attention.
Okay.
Thank you.